we'd like to get... Oh, there it goes. Okay, we'd like to get restarted. If everybody can take your seats, please. So, are they going to throw eggs? All right, so finishing up the afternoon, our next speaker is Dr. Ron Lippmann. And hello. You'd think that the air conditioning would bring him back, Mark, but yeah. Anyway, so we'll just give the group coming in just a minute or 30 seconds here.
You know any jokes?
No. But I want to get off the stage before you guys start throwing apples and eggs and everything at Ron. Actually, as we were putting this program together, all of a sudden there were a whole bunch of emails that were flying back and forth related to some of the discussions that were earlier today about the color caps and some of the other things with the vials. And so actually, Dr. Lippmann, who is the medical director for ISMP, as well as being an anesthesiologist, we asked him to change his presentation. And I don't even remember what you were going to talk about, but we knew this was a really hot topic in terms of the whole color issue. And so we're really pleased to have Ron kind of give, as old Paul Harvey used to say, kind of the rest of the story or the other side of this, because I think it's the perspective is much broader than just anesthesia. So welcome.
Thanks. Hello, everyone. Good afternoon. Thank you so much for having me here, Mark. This is really great. You know, the best thing about speaking at this meeting in the afternoon is that all the other speakers have already said everything I'm going to say. So it's going to be a short talk. Even people have the same slides. How did they get those? I don't know, whatever. So Tim's right. They changed the topic on me like, yesterday, and no. But I just kept the old talk anyway, so I just didn't tell anybody. All right, so I'm here representing ISMP, the Institute for Safe Medication Practice. Hopefully you all know that by now. And they have some very specific recommendations for you. Now, there are too many to talk about here today. So I went over this with Mike Cohen, our president, and we chose mainly 3. But I need to give you a little bit of background first. 2 things of background that it's really important, as Tim said, to put everything I'm going to say today into perspective. The first thing is that when ISMP was created 43 years ago, they started getting reports of all these medication errors from around the country or even the world. And then when Mike finally made this a formal process and had the website, the reports kept pouring in. So a lot of what we know today about medication safety is not based on prospective trials. It's too difficult to do a prospective trial looking at medication errors. We all know that. But is based on 43 years of their experience seeing the same errors come through their office day after day after day. And it's really unbelievable. I talk to Mike, I don't know, we email probably every day, and we talk on the phone maybe a couple times a week, and every time we talk, he goes, "You're not going to believe this, what I got today with these stories." And we occasionally golf together on weekends, and we spend like the first 9 holes just talking about all the medication error reports he got that week. It's really entertaining. So this is the, so you all know, this is the ISMP website, and there is a way that you can go in there and report an error, and this is a very busy mechanism. Okay, so the second thing that ISMP would like you to know is that we all here are very insulated in the operating room, and we think that the world revolves around us, and I don't mean APSF, of course. I mean that we just don't see what else is going on outside the perioperative environment. And ISMP would like us to do so. And the reason is because when you think about all the different types of people in healthcare that give medication and report their errors into ISMP, we're a very small piece of this pie. I mean, there are so many other people that are subjects of medication errors. And we have to figure out a way to standardize everything, just like you all have been talking about here before, so that we can all communicate with each other on the same page. So the first thing we would like to recommend to APSF and to the anesthesia community is to have the expression of drug concentrations on the vials and pre-filled labels the way that USP says it should be, and I'll explain. In previous lectures, you heard about USP 7. USP 7 has 3 rules for medication labeling. The first is that for containers, and I'll define what a container is in a moment, for containers less than 1 ml, which really doesn't apply to us, let's face it, very, very often, you have to put the amount of milligrams, this is what's on the label, the amount of milligrams in how much is in that syringe. That, in my practice as a pediatric anesthesiologist, we will occasionally get an antibiotic or another medication that's sent to us pre-made by the pharmacy, where it's in a 1 cc syringe and there's less than 1 ml in there. But let's face it, in the scheme of things, this is not very common. So for containers that are exactly equal to 1 ml, the way it should be written is the number of milligrams per ml. Not 5 milligrams per 1 ml, but 5 milligrams, as an example, per ml. And again, in most of our practices, we're not going to get syringes that are exactly 1 ml. But what we will get are the third category, for containers that are greater than 1 ml. Here's how it should be labeled. With the, is there a pointer on here? Yeah. Okay, so USP 7 says that the total milligrams has to be prominent and first, and the milligrams per ml has to be second. That's one example. Here's another example of units per 5 mLs or 5,000 units per ml. Now, in anesthesia, we don't really work that way, do we? We would prefer it the opposite way, but this is how the rest of healthcare operates. This is how USP 7 operates. And what happens is that ISMP gets a lot of reports of hospital systems where the anesthesiologists have demanded to their medication suppliers that the labels be provided in the opposite way. And when then these syringes get distributed throughout the hospital, nurses who are giving these medications outside the hospital on the wards don't know this, and this is where mistakes are happening. So here's an example of the right way it should be. Oh, so sorry. So a container. A container is defined as any vial or any pre-filled syringe. However, outsourcers, distributors like PharMedium and the rest, do not have to comply. I wouldn't exactly say they're exempt because the wording doesn't say they're exempt, but they're not included in that container. So that's why when anesthesiology groups get their medicines through their pharmacy, through whatever buying group, through third-party, drug aggregators or outsourcers, there's just an incredible variability in how the labels can come. So here's the way it should be. Just as I described, 40,000 units per 4 mLs, that's the total. And then next to it or below it, less prominent, is the amount of concentration per volume. So this slide I know was shown already today. This was an actual case that ISMP received, one during the succinylcholine shortage a couple years ago. One anesthesia group had 2 different types of suppliers. And you can see here that, I'm just trying to make sure I hit the pointer. This succinylcholine up here shows the 200 milligrams per 10 ml. That's the right way. That's the way that USP 7 says it should be, and that's the way that ISMP would like anesthesiologists to adopt. Down here is the wrong way. Even though this looks a little bit better color-wise, right? It's a little bit easier to read. This shows the milligrams per ml first, and that's not compliant with USP 7. However, it's not a criticism against this supplier because they do not have to, by law, comply with that. So this is a report we received earlier this year. I think, Steve, remind me, this might be in the next newsletter, I think. So this anesthesia group had ordered their ketamine, and they wanted it in milligrams per ml, which is not what USP 7 says. The ketamine syringes were distributed outside the operating room, as many hospitals do for the emergency room, the ICUs, whatever. And a nurse was following an order to give a patient 10 milligrams right, for pain, for sedation in an ICU. And the nurse looked at the label and automatically assumed that there was 10 milligrams in the entire syringe. So the patient got a 5-fold overdose. So these things are not rare. We get reports like this all the time. Okay, the second thing ISMP would like you to know about color coding is that it doesn't work. It just doesn't. No matter what we think, it doesn't work. Listen, come on. Color, what we all know that colors promote safety, right? We go, this is a part of daily life. We are used to colors in our lives. We can standardize in pediatrics. I know the colors of these blood pressure cuffs. It makes it easier for me to reach to something easier depending upon the size of the baby I'm taking care of. When you're in the midst of a code or in the emergency room, you want to put on the leads really quickly. We know from medical school that these have the colors that, are standardized. And, we know that colors can be associated with good feelings, right? But everything in context, right? Here, the red, white, and blue gives us good feelings, right? But there's red, white, and blue that gives us bad feelings. So, all in context. So this was sort of codified in the mid-2000s when the ASTM had come out with their color coding chart for anesthesia meds, and ISO did, and the ASA, if you look on the ASA's website, they sort of took a combination of both ASTM, iOS, and ISMP, and that essentially codified what we all know today as the anesthesia colors. Now, it does make sense in a certain, in a certain perspective, it makes sense because those of us who work in the OR, which is most of us here, know to reach for a certain color, and that's our cue, like Julie was talking about before. And the rationale behind that is that if we make a mistake, if we choose vecuronium instead of rock, if we choose fentanyl instead of morphine because they're both blue, at least the error won't be as bad, right? Because the drugs are in the same class. Well, that's the theory. So should anesthesia syringe labels be color-coded? And that's a really difficult question because we get our anesthesia syringes from so many different places. So I just took a picture of my cart the other day, and there are different ways we get it. One way is self-prepared. So there's propofol, obviously, and as you can see, I didn't put anything on the label because I know it's propofol. Come on. And what else could it be, right? And this is ondansetron, and this, these are color-coded. The ondansetron's white, so I actually have to, Julie, I have to read that. So that's one way. But we also get syringes by our pharmacy. They're made several different ways. Sometimes, actually in my institution, the pharmacist gave this up, but they were making some under the hood. Now we use the Riva robot. I have no disclosures. This is just what we use. I'm sure there's many varieties of robot out there. And essentially what happens is they'll deliver us a product where the drug is pre-filled, pre-labeled, but we have to put on the color ourselves. And I know that's not the case in every hospital. Every hospital is a little bit different. And so that's why it's so difficult to standardize color syringes between hospitals, between centers, and it's probably in the large scheme not a good idea. There's 503 B Outsourcers. I know you saw this picture before. It's from the ISMP website of mistakes that has come through. And I mean, there's many different ways. If you were in the room here while in the break, people had sent in all their pictures of the different kinds of medications that were all lookalikes. This is no surprise. But see, color coding is not going to help there because so many different vials and syringes are the same color, but they're not the same drug. And, some of us, I'm sure you guys get this too. We have, I think, our bicarb, our epinephrine, maybe I think some of our calcium comes right from the manufacturer in these boxes. And when you open them up, there are these, what do you call these things? Bristagets or something like that. And there's no labels there at all. They all look the same. So there's so many varieties of the way that we're going to get syringes in the future, especially if we give up vials, which we should, right? We should go to pre-filled syringes when they're available. I know it's not an easy solution. They're not all available yet. And what if you're colorblind? Look, this paper is in print. It just came out in BJA this week. It was really cool. I was just scanning through the table of contents and I saw this. And here's what the normal colors look like, and here's what if you're colorblind. And so, it's not, colors don't always help us. This, if you can go to the BJA website and find this paper, it's not published yet.
And then human factors engineer and I wrote the contrarian view.
Oh, good. On this paper? Excellent. All right, good. So how about vials? Vials, it's another story. I mean, a friend of mine sent me this is from their medication cart. I mean, how are you going to pick out the right drug by color here? So many are similar, and let's face it, once you flick the cap off, then there's hardly any color left, right? Except the label, and the labels can all look alike too. So vials are probably not a good idea either. And one of my former fellows, Amanda Brown, just sent me this. This came from her Pyxis. She wanted to get on Dancitron. And, the reality is that most of us are using so many different manufacturers of generic drugs that they're all going to look different. And to then go ahead and ask all these different generic manufacturers to make it with the same color is going to be very difficult. So what's better than color coding? You've heard it, right, barcoding. There's no question about it. This is the future. So we have the Epic module. Again, I have no favoritism toward any EMR or anything like that. This is just what we have at CHOP. And this is the, those of you who know it, this is the little device that you scan the patient when they come in the room. You'll scan the barcode on their wristband to make sure that they're not an imposter. And so when you want to give a drug, you have to code, all these pre-filled syringes will come with labels that have barcodes on them. And the point here is that, look, anybody who's given anesthetic for more than a few weeks knows that at some point it becomes very rote. It happens to all of us. We look for a syringe, we pick it up, and we may not concentrate on the name of that drug, just like Julie was talking about before. But what this does is it forces us to do two things. It forces us to look at the syringe when we're aiming the beam onto the barcode. So that's one visual cue that he's actually picked up on Dancitron and not phenylephrine. And then what happens is, at least in the Epic system, I don't know the other systems, is the medication administration pop-up box comes up. And that forces the anesthesia provider to look there, make sure it's the drug that they intended, and that it puts it all into the EMR. So this Epic does have this available. Jeff Feldman is going to get this working for us, next week? 10 days, good. But these things are available. They are the future. And there was some mention of how do you incent anesthesiologists to do this. There's one nice article that appeared in A&A a few years back about getting a group to use the codonics machines. And I don't know if you guys know this. I don't have a slide about it, but I love this article because they tried to promote it to the department. And after about 13 weeks, they could only get as high as about 40% buy-in. But then all of a sudden, on week 14, it shot up to 70%. Anybody know why? Do you remember the paper? Coffee, very good. They gave them coffee cards. And even with a free coffee, they could only get it up to 70%. So you have to build in other incentive mechanisms. I mean, with pre-filled syringes, the codonics doesn't use pre-filled syringes. But if you do have a pre-filled syringe, it incents you to do the right thing. And if you get a report every month of, the big thing now, at least in our department, I know other departments as well, is it incents your compliance with your bonus. So that really helps too. And then you could put in warnings, like if this patient's allergic to morphine and you're trying to give morphine, you could program it to however you want. Okay, so 3 is, we just wanted you to know about some other reports and the kinds of things that we pick up at ISMP. This was a report we received of a particular company. This was Nephron Pharmaceuticals. They came with a packaging with phenylephrine and succinylcholine. Really good, right? Until you turn the syringes around and they looked exactly the same. So here's a really nice example of how ISMP really contributed based on this. That we contacted Nephron Pharmaceuticals, and within literally weeks, they had redone the labels. and now they're different on front and back. So this mechanism does work. Even if color coding was there, there's different concentrations, right? This is the same color. It's that purple of vasopressors, yet the concentrations are different. And the only way to tell them apart is by vigilance, right? The ASA's motto, vigilance. Where's Linda? Vigilance, right? But vigilance doesn't work. It just doesn't. We just cannot rely on vigilance. We have to rely on technology. Just another example, phenylephrine. So what are our conclusions? What would we like APSF to recommend to the anesthesia community? The label should conform to USP 7. Show the total dose per the entire syringe first. It's much easier for anesthesiologists to get used to this than to try and get everybody else in the hospital on board to the ways that we want it. And then you're at the mercy of the vagaries of every individual anesthesia group. Color coding is not reliable. It's not feasible, especially outside the operating room. And bar coding is the most feasible solution now. So I told you I'd make it quick, Mark, and I look forward to some interesting questions and discussion. Thanks.
Thanks, Ron. Our next speaker is Dave Jamison, and Dave's Executive Director of Health Devices Group of ECRI. I don't know, is anybody not familiar with ECRI? Probably everybody is, but ECRI is really focused on safety, I think, since its inception. And so Dave's going to talk a little bit about the IV medication administration potential for harm. Thanks, Dave.
Well, hi, everybody. I hope we can keep you awake here after the ice cream. And I can validate that some of you don't know about ECRI because I asked a few of you didn't know. So I will take a minute to talk about that when the slides come up. In a way to get started, I'll introduce myself. I'm an engineer, not a clinician. I've been in industry for most of my career, but the last 3 years I've been leading ECRI Institute's health devices team, which is basically, the way I describe it to most people is like Consumer Reports for medical devices. So you know how when you're going to go buy a new washer, dryer, or refrigerator, you always look, right? Or at least I always look. Maybe most of you do. Hospitals really should do the same thing, right? Because they don't want to get ripped off. They don't want to buy something that doesn't a good fit for their workflow. They want to know what the pros and cons are of the different machines they're going to buy. So we provide that kind of information. So I have a group of scientists and engineers that work for me, and we test everything from sutures to CT scanners, MRI machines. We also test most of the technologies that you guys deal with in anesthesia in the operating room. So I was asked to speak about the potential for harm in IV medication, and let's get started with that. So ECRI Institute, 50 years old, a nonprofit. It's been dedicated to bringing science, scientific research to find out which medical procedures, drugs, devices work the best and to improve patient care. And we're very independent. We tell manufacturers we work with, we love to work with you guys, but we're going to publish what we find. That's what we do. And I have no disclosures. We're not allowed to own any stock in medical device companies or anything like that. So we continue to learn about and investigate incidents of infusion errors. Now, in a differently than ISMP, which has their website you just heard about, we have a couple ways that we find out about equipment or technology-related issues, and I'll describe them to you. One is we have an accident and forensic investigation team. Some of you might know Mark Bruley, who for many, many years ran that group. And the fire safety video that hopefully most of you are aware of for high oxygenation was put together by Jeff Feldman, him and others. So that group has 3 PhDs that roam the country helping hospitals get to the root cause of serious incidents or deaths when they just can't figure out the root cause, the tough to solve problems. So ECRI finds out things that way. We also have a website where we call it our problem reporting network. And anybody doesn't have to be a member of ECRI Institute. any hospital or any person can report a medical device problem, and we promise to look into it and get to the bottom of it. And we bring that information together and then start to draw conclusions about trends and things we've learned. And so those informations plus information from testing devices in our laboratories are the things that I'm going to speak about today. When I asked a couple people who work for me that test pumps all the time, you know, what are the most fundamental things we should say about the use of IV pumps in anesthesia and safe use of IV pumps? They said, know what you are administering. Well, it sounds simple, but I've heard a few stories today that, well, we weren't really quite sure. We were going too fast or whatever. Secondly, we ought to use these software controls and smart pumps and technology. And, you know, in a lot of ways, technology is great. I'm an engineer. I love technology. You know, iPhones, iPads, everything, right? But, so it can help. We should use them more. And I know that change is hard, and for this audience especially maybe. But that's been my experience in designing equipment for you guys. But that's not bad. That's who you're all about. But at the same time, there's some change that will be needed. And the third thing is really where I want to focus the most, is to use the simple physical actions as an adjunct to the technology. And we'll talk about that a little bit. And I think those things are going to be important as you move towards more technology and more smart pumps, because you're going to need the belts and suspenders, right? You're going to need to fall back on simple actions that you can take, like roller clamps and looking at the drip chamber and things like that. So how do we hear about these problems? I drafted this around to a couple folks, and a couple good questions came out like, well, how do we hear about these? Are there common themes? How many of these kinds of things do you get? Is it thousands? Well, I think in contrast to maybe what Ron gets, we don't hear about every infusion issue that happens in hospitals, even though most hospitals do report things to us. But we do hear about the tough ones. And I'm going to focus a little bit on some of the tougher ones. A lot of them have to do with broken parts or cracked doors or misloaded pumps. And those are often reported to us because they're difficult to figure out. And obvious misprogramming, of course, is a major issue, but not often reported to us. And we think there's an awful lot more problems than are reported to us than the few dozen we hear about each year. Let's keep going. So one thing you might not know about infusion pumps is that even though there's always, I think, always an alarm if there's gravity flow or free flow occurring, it might give you that alarm, but if it doesn't give you the alarm, that doesn't mean that free flow is not occurring. So the alarm means that a particular part of the device has engaged, but the system is not able to measure gravity flow on its own. It doesn't measure it, okay? So when certain things happen in the pump, it'll engage the anti-free flow element, and it'll give you an alarm. But just because it's not alarming doesn't mean that there's no free flow. I don't know if I was very clear with that, but. So this is something to keep in mind. Technology can be great, but it has limitations, right? And it doesn't have a sensor that's just watching to see that happen all the time. And something you need to think about. If you look at the user manuals for your IV infusion pumps, you'll find that all the manufacturers will tell you to use the roller clamp as the primary method of ensuring that no flow is going to the patient. So when you're messing with the door that doesn't seem closed right, or you're reloading, or you're doing something that could in some way potentially cause more flow than you want to have happen, you should be using that roller clamp. And you know, there's also failures, of course, of a pump that can cause gravity flow. And a lot of times what we find is that if we do an investigation, we find that there's damage that's been done to the pump. It may have been inadvertent in just some way somebody loaded a set or something, but that can lead to malfunction, which might not be obvious to you. And this is where, you know, really can be an issue. So if you could look and see the drip chamber and maybe notice something isn't right, or, you know, you're just going to have to use all your senses. I was talking to somebody earlier at breakfast or lunch about anesthesia sounds, and, you know, using your senses I mean, to me, that's one of the unique things that I've been in this business a long time, and the machines used to be pretty loud with each breath when I was in the OR earlier on. And maybe they're quieter now, but you've got to use all your senses and looking for any clue that this doesn't seem right. So ECRI Institute publishes a top 10 list of health technology problems, and we publish it each year. And a lot of hospitals use this in their quality departments, or maybe some of you have been involved with work groups that have used this list to help put little initiatives together to improve. And 2 years ago, on the very top of our list was infusion errors can be deadly if simple safety steps are overlooked. And we defined the problem about that safety mechanisms are effective, but they can't eliminate all potential errors. And they can fail, or may just be broken. And it's something that you need to be aware of. How many of you have walked into an operating room and seen a pump that looked damaged, or where it's a fairly significant number of hands went up. So, you're working with equipment that takes a lot of abuse, right? It gets a lot of miles. You wish you had the frequent flyer miles of that pump. And, it's expected to last a long time. It's expected to do the job perfectly every time. So you're going to have to observe, just like I guess when you walk out to your car, do you look at the tires to see maybe there's a low tire? You need to be observant. And we think that it's those kinds of things that can make the difference. So, I was just chuckling because Ron's talking about technology solving the problem, and the technologies guy's got to talk about people solving the problem. But I think there's actually both needed because it's a tough problem. It's a tough problem. Key recommendations: don't use pumps that look damaged. Maybe that's obvious, but you're under time pressure. Probably nothing wrong. I just used it. Whatever in your head, the video is rolling. But think about it. It may do something you don't expect if it looks damaged. I wouldn't use it. Close the roller clamp at the appropriate times. Observe flow in the drip chamber and just look for what seems right. And I guess this is something a lot of you are in teaching, and I'd encourage you to consider, using some of these slides and some of our other top 10 stuff in your teaching, because, I think that the younger generation may be expecting the phone to do everything for them, and the technology is going to have limitations. It always is. So we just need to be aware of that. So don't implicitly trust that the pump technology will be perfect, but please use the simple safety practices and don't overlook them. So that's my spiel for you today. So I hope that was worthwhile. Thank you very much. One other thing I did want to mention, there was a comment earlier about the National Guideline Clearinghouse that the ARC has stopped. ECRI Institute was the prime contractor that actually managed that, and we're going to take it over. So it's going to exist. So I know that the people that are running that would ask for your contributions and interest and support in helping make that happen. It's going to cost us some money, but we think it's important too. So let you know that. Thanks a lot.
Thanks, Dave. I just add one comment, and that is from the perspective of somebody that was in the device industry, infusion industry, it would be helpful oftentimes, I think, if the devices were used, because a lot of times I think my experience has been that anesthesia uses a lot of gravity, especially for the infusion. So anyway, can you pull up my slides if you've got them? Oh, good, thank you. So what are the advantages of going early in the program is you don't have to worry about the fact that somebody's already talked about what you're going to talk about. One of the disadvantages of going last is there isn't much left to talk about. So I actually ended up putting my summary slide as the first slide, and then from that point on, then probably everybody can just go to sleep. But anyway, so I think, let me find this here. Back, blank, forward. Here we go. In terms of disclosures, I recently retired as the VP of the Center for Safety and Clinical Excellence at BD, and recently became a consultant to the medical affairs group at ICU Medical. I did want to give special call out to Nat Sims from Mass General and John Beard from ICU, because as a non-anesthesiologist, I wanted to get some input from anesthesiologists as to whether or not this made sense. And so we did go back and forth quite a bit. So I thank JW, who's here, and Nat, who I think wishes he was here but didn't sign up. So he didn't quite make it. So here's my summary, and I think this has pretty much already been covered. But so the medication process in anesthesia is unique in that the anesthesiologist, and we've already heard this, prescribes, dispenses, prepares, administers, and documents all of the medications and fluids, and that typically doesn't happen outside of anesthesia. The current generation of smart pumps has replaced the older pumps that were actually designed primarily to be used just in anesthesia. For the most part, those of you who are my age, been around for a while, you know that you had, and I'll have a slide with some pictures on it, some of the devices that didn't go outside of the OR. They were intended to be used in the OR and stay there essentially, which caused many problems for patients who were being transferred back to especially to the ICU. For inpatient use, barcode medication administration and smart pumps with wireless connectivity are connected seamlessly now with the EHR. And I was talking to Adal. We think there's probably about 400 hospitals now around the U.S. that are actually doing that, seamlessly tying the barcode medication system and the pumps together, so that we have basically created from smart pumps, we've created now what we're starting to call intelligent infusion systems that both auto-program, and I think, and you mentioned that, but auto-program as well as auto-document, which is a huge step forward. And we're really excited about that. With a lot of things have come together with the EHR vendors wanting to finally address that with wireless connectivity to the infusion devices, and I think that's pretty exciting, and hospitals that have implemented that have stayed with it, which is always a good sign that they really, especially the nurses, are getting a lot of value. Slight modification to the inpatient BCMA and smart pump interoperability are required to fit the unique OR infusion and injection practices. And Fran, you mentioned that in your talk just briefly, that that's the direction that we need to go. And I know our first speaker this morning, Dr. Bodell, talked about the fact that they've been doing that for a long time with a homegrown system having their IT. So they must have a little higher support from their IT than what some of the others have said that they get or they don't get. And technology and software for operating room drug use, they offer major safety improvement, but will require significant practice changes, including the barcode scanning, which we've heard about multiple times today, documentation before administration. And I think that's, at least as a pharmacist and thinking about this, and I've talked to Dr. Bates, who's speaking tomorrow, if you have a decision support tool, administering and then documenting is going to tell you that you made an error, but it's not going to prevent it. So the documentation or documentation before administration is key. Creating decision support tools, and I think beyond the allergy the alerts that we've talked about are going to be really important. Standardization between the OR and the inpatients, and then compliance with the use of these new processes. And I think compliance is part of the culture, and it's really a huge part of all this. And we've heard that about, you get a card to go to Starbucks and get some coffee, you'll put labels on the syringe, but if you don't get that, you're not going to do it. So that's obviously, I think, a cultural issue. So I'll go through the slides that I had that, I apologize, I'll try to go through these quickly because most of this you've seen. But as I mentioned earlier, infusion devices over the past 3 decades have kind of come and gone for the most part for those that were created for anesthesia. So some of you may remember the magnetic plates that you put on the device. That's the second one on the left there, and that would be the propofol, or I don't even know if we had propofol then, but whatever the drugs were. Dual channel syringe pumps, Harvard pumps that were only used in the in the OR. The pharmacokinetic pumps, which never have made it, and Dr. Black, I'm sure you still wonder when and if and when that's ever going to happen in the U.S., but the pharmacokinetic pumps that had chips in them that would do the TIVA or the automated infusions for anesthesia. And the one on the right there was a pump that I think was just used at MGH that was actually an ambulatory pump that had a barcode scanner, and so it was used. And I'm not sure if it was actually used in anesthesia. Nat sent me that slide, but we forgot to ask him exactly what it was. But these devices were not intended to follow the patients. I was surprised to learn that some of these devices are actually still available, but not from the original manufacturer. There's labs, I guess, that have, or manufacturers that have bought them off of like eBay, and they fix them up. And so some of these may still be in use, which that was a big surprise. And I've heard of hospitals buying up old pumps to have like a junkyard because they like the old ones, and so they could strip parts off of them. But apparently you can actually still buy these $600, $800 or something. I'm not sure that's a good idea. It probably doesn't have a lot of safety features, but they are still available. So in around 2000 or so, after the Institute of Medicine report came out about the number of medical deaths, we started to see, and actually even before this, we saw in some of those earlier pumps in anesthesia, they did have some early dose air reduction systems. ECRI coined that DERS or dose air reduction systems. We called it guardrails when I was with BD, and that kind of really stuck. It's kind of like the Kleenex, but all of these devices now have the capability. They're not shipped with the DERS, but they have the capability of having that. And it's really enhanced the safety for all the different types of devices, the LVPs, the syringes, the PCA. And I think one of the things that's helped to move this along is that that's the only thing you could buy. So all infusion devices over time were replaced. The old ones were replaced with the capability of being smart pumps. So what have they done? They basically fostered the development of drug dose soft and hard limits. It's amazing to me that one of the toughest parts of implementing these in the early days was kind of coming up with where would we have a soft limit for low and high? When would we have a hard limit? Those limits just never been established for the most part. And we saw a tremendous variability in how hospitals approach that. I think it's something that I'm not sure that ASHP has actually tackled where we should have soft limits and where we should have hard limits. But and one of the very first things that we ever learned was, pardon? That's the next stage. But I remember when we first put the soft limits in and hard limits capability, and it was at the Brigham and Women's, and we were doing a study with Dr. Bates, and we found that propofol was the number one drug where we saw overrides, primarily by the nurses, and they were just blowing right through the soft limits. And so then we put in hard limits, and we found that they just called it a basic infusion and didn't tell the pump it was propofol. So I remember the CNO says, I don't know what's worse, the soft limits that they blow through or hard limits where they don't even tell the pump what they're giving. And then Dr. Ramsey told me, when I showed him some of the data that we had about how much propofol was being administered and how sometimes the old practice was just turn it up in the ICU until the patient quits extubating themselves or whatever. And sometimes you could actually see from the logs there was a whole bottle was given. Fortunately, it's got a pretty short half-life, but it was pretty amazing some of the things that we actually saw. And I remember Dr. Ramsey told me that they kind of got onto that at Baylor, and so they started looking at it. And so what the nurses were doing, unfortunately, was just taking the set out of the pump and running it by gravity. So then they didn't get alert. So, there always are workarounds. But they also forced us to start standardizing the concentration and also the dose unit standardization as well. As I mentioned earlier, that was a bit of a challenge between the OR. It was also, though, a challenge between the the ICU, cardiovascular, everybody had their own way of doing things. So we really had to struggle to get that. But we did prevent a lot of inadvertent programming errors. ISMP, I think at one point called it the key bounce and fat finger and somebody missing a decimal point and all of that. So we know from the logs that there were a lot of these errors that were actually prevented. As I mentioned about the propofol and many other drugs, we saw a high degree of variation in unsafe practices, which we couldn't see before because now we had logs that would actually show us what was happening. And that, as Dr. Bates said, we worked with him in the early days, he said this provides a treasure trove of previously invisible infusion practices. And I think that the intensivists in the ICU oftentimes didn't know how the propofol was actually being administered by the nurses. Some of the things that we were able to see from just collecting that kind of information. It also allowed capabilities and features to be matched with the practice areas. So a pump that before this, an infusion pump was a vanilla version or a rocky road version. Biomed didn't dispense these for the individual patients. They dispensed one type of pump that went everywhere, with the OR, the ED, the PEDS. And one of the things that smart pumps did, and I think they didn't get as much credit for this, but by telling the pump where it is, it could be configured for the particular population it was going to be used in. So is it going to be used in the neonatal, so you had limits, pressure limits, rate limits, all this, or is it going to be used in the adult area or OR, wherever? I think that was a real big safety enhancement that, like I said, oftentimes doesn't get a lot of credit. Also, the wireless communication really facilitated managing these libraries. Now, I didn't realize until relatively recently how big of an issue management of these libraries is with the drug shortages. That is huge. And one thing I would caution all of you about is when pharmacy or whoever it is sends out a new library, you don't immediately get that in every pump. It can take a very long time for those libraries to get uploaded. And then the devices typically have to be cycled, the power has to be turned off, turned back on. So it can be a very, very long delay. So just because you're sending something out doesn't mean that instantaneously. It's a lot easier to do that in your Epic or your Cerner with one push of a button that goes everywhere. On the infusion devices, if you have 1,000 infusion devices, don't think that they're going to all get this immediately. It may be days or weeks actually before that can happen. What the devices have not been is associated with the patient who's receiving the infusion. Up until relatively recently with this interoperability, there was really no need to do that, although it would have been nice to know if you went back and looked in the logs, what patient was this, if you wanted to go back and look at something. But for the most part, the infusion devices were never associated with the actual patient. They didn't have any awareness of what they were intended to do. So if you told it dopamine and you really had dobutamine, it was fine. You know, it didn't really care. And before the smart pumps, obviously, there with a 10,000-fold rate range, any rate was okay. So that obviously was something that we were able to do. But they didn't know what they were supposed to do. Didn't prevent drug mix-ups because the barcode system that was being used for all other medications in the inpatient wasn't being used for the with the infusion devices. So that was a big miss. Some of the most critical meds were not part of that system. It didn't force the use of the dose error reduction system. So at least with the pumps that I was familiar with, we had guardrail drug or guardrail fluid or basic infusion, and oftentimes the basic infusion was taken or was selected just because it was easier, and I'm just going to do a rate and a volume anyway, so why do I care? We didn't record the identity of the caregiver or the reason for the overrides, although we were told on our Pyxis division that oftentimes somebody just picks something out of the list if they have to do an override that may not really have anything to do with why they did the override. So that was not something that we were ever able to really pull out of there. Up until recently, it didn't populate the infusion records. It didn't maximize the value of the inpatient barcode medication administration system, as I mentioned. And I added this based on the conversations today. They certainly haven't reduced the complexity of the drug shortage issue. in terms of trying to get these libraries to match what is actually what's being dispensed by the pharmacy. Now, in 2009, when we did the first focus on this with we've all heard of the standardization, technology, pharmacy, and culture, I was lucky, had the real good fortune of working on the committee on technology back then with Dr. Mike Olympio, who is not here, but many of you know Mike. And we implemented with Wake Forest the infusion pumps, and he was a real zealot on training. And at that time, we were talking about training, and anesthesiologists would say, park a nurse outside the OR for a week, and if I have a question when I put in a new infusion pump or whatever, I'll call them, but otherwise, I don't need to go to any training. And Mike insisted that everyone in anesthesia be trained, including all the attendings. But we implemented that, and they basically did the standardization, the technology, the pharmacy, and the culture, and we wrote about that shortly after that conference in 2009. I was disappointed that was the only article, I think, that ever came out about standardization, technology, pharmacy, and culture, which Dr. Stoelting had basically really pushed hard. But we were able to show that by standardizing the infusion devices between the OR, between the ICUs, having all the training, getting the compliance with the use of the libraries and everything, it made a huge difference. And their time to transfer a patient from the OR to the ICU was basically in seconds rather than minutes, and nurses not recalculating doses and concentrations that were different, all of that. And so that was, 8 years ago, I guess, or when we wrote about it. So it was probably 10 years ago when that actually happened. So if we look at some of the challenges, and I think most of this has actually been talked about, but when we look at if trying to improve the infusion safety, and somebody mentioned this earlier, there's no order, first of all, for the anesthesiologists. They're not currently putting in an order, so there's no pharmacy review. Oftentimes there's no barcode on the label, so although ISMP says scan the barcode, if there's no label on there, you're not going to be able to scan it. Oftentimes there's no barcode scanning capability, even if there is a barcode label, so that's clearly a near miss. The selection of the drug and the concentration is a manual process if the device is being used, and we need to fix that. Infusion pumps are typically used for medications and not for fluids. Dr. Beards tells me that when we get to goal-directed fluid therapy, we'll be using a lot more infusion pumps. And the pumps and the concentrations are oftentimes not standardized, both with the dosing units as well as the concentrations. And as I said earlier, the BCMA process doesn't really fit. What happened? So, wow, some of that's upside down. I had to change my slides from something size to some other size. I kind of screwed some things up here, I think. But anyway, in terms of the inpatient, the physician writes the order, pharmacy reviews it, the nurse logs into the EHR, they scan the wristband, they scan the pump, it assigns the pump to that particular patient, they scan the medication, they confirm it's programmed, and the documentation is automatically back to the EHR. And that's the system, I think, Fran, you talked about in terms of where we need to go from an anesthesia standpoint. What's missing in the anesthesia part is there's no physician order. So exactly how that works, I'm not sure. This is all pretty new, and other than the folks that have had homegrown systems, I'm not sure how many hospitals. I haven't been able to identify hospitals that are actually doing this. So anyway, I'm getting the hook to wrap this up. So I think I'm going to stop at this point, and, so you'll pay for my airplane ticket, right? So, thank you very much.
We do have on the list a panel of the previous 3 speakers, but I think what we're going to do, we're going to do the next 2 speakers. So the speakers will be done, bring all 5 of them up together, end with the panel, and we'll be done at 5 o'clock. Somehow I made a mistake and forgot to put 15 minutes in there, so we're going to use that to make up time. It's good to not be very good at math. Okay, so next, Frank, you want to come on up? Where are you, Frank? Oh, here he is. So Frank Overdike's our next speaker. He's an anesthesiologist in Charleston, South Carolina. He's had an extensive history of leadership in our specialty and as well as in the corporate world. So Frank, thank you very much.
Thank you. Thank you, Mark. All right. The opioid crisis, really a public health tragedy outside the hospital, but we're going to spend 15 minutes or so talking about the in-hospital opioid crisis, specifically on wards, on medical surgical floors. It's been raging a lot longer than the out-of-hospital crisis, I think, and claimed thousands of lives. Just to disclose, I'm compensated to lead a steering committee for Medtronic on a global study on continuous oximetry and capnography that just finished recruiting, and you'll hear a little bit more about that in a minute. So what I want to do is basically do a little condensed chronology of where we were with the issue of preventable harm from opioids in hospitals from 2006, when APSF convened the first conference, to today, in terms of significant evidence, in terms of patient safety organizations' guidelines, and some regulatory guidelines as well. And let's start with 2006. The first meeting was basically Tim Vanderbeen has been probably the most significant person behind the scenes to be driving this effort, and then him and Bob Stoelting and the rest of the APSF board convened this meeting. After 2 days of good food and drink, we came up with some recommendations. I'm going to cut to the most important ones. No patient shall be harmed by respiratory depression in the postoperative period. 0 tolerance. Why should patients be at risk of dying or having an anoxic brain injury from pain treatment? That's an important bar to set. We also came to the conclusion, there was a consensus that continuous monitoring could prevent a significant number of cases. Sounds obvious, but it's really the first time an organization talked about continuous monitoring of patients on a ward or a medical surgical floor setting. 2011, 5 years later, we came back and had more good food and better drink because we had more recommendations, but we actually moved the bar forward. The most significant of these at that time were all patients should have oxygenation monitored by continuous pulse oximetry. Monitoring modalities that measure the adequacy of ventilation is indicated when supplemental oxygen is used. So that basically speaks to the fact that patients on supplemental oxygen may be hypoventilating and may not show changes in their oximetry till later. So that speaks to the delayed effect of monitoring with oximetry. And lastly, applying monitoring selectively based on perceived risk is likely to miss respiratory depression in patients without risk factors. In other words, risk triaging, not something we advocated. We wanted everybody to be safe. We wanted to take care not of most patients, but of all patients. The Joint Commission came out the next year, 2012, with a sentinel event alert, number 49. They don't do many of these, so people pay attention. And they basically said 3 things. They want hospitals to adopt effective processes and safer technology to increase monitoring. They didn't say how. They didn't talk about continuous, but increased monitoring, we'll take that. They said, well, we want people to risk stratify. So apparently they didn't share the APSF's committee's consensus. And lastly, they said we need to educate prescribers and frontline providers on strategies and signs and symptoms of ORD. Well, that education didn't make it to Brian. Let's see if we can get, we have the version here without Brian's picture, but that was not intended. We actually have you have an old version of that. But anyway, the issue here was, this was a patient who came, a trauma patient who was given, had trouble controlling their pain in the middle of the night. And the PA, the physician assistant, after several calls of uncontrolled pain, changed the pain order from 1 to 2 milligrams of morphine to 2 to 4 of Dilaudid. And the nurse at the front line went ahead and gave that order, and you can imagine what happened. And Brian suffered an anoxic brain injury. On further examination of the case, this PA was unaware of the 7-fold difference in potency between hydromorphone and morphine. So a sad example, tragic example of a medication error, it falls under that category, that could have been prevented. 2004, CMS came out with this memorandum. Now, as somebody said, CMS is like the E.F. Hutton. When CMS talks, people listen. They said, well, we need to reassess patient risk assessment and appropriate monitoring, particularly for postoperative patients receiving IV opioid medications. What happened to this? This was sort of a soft recommendation. They did include the ISMP best practices, but then they went through the trouble of saying on top of that, not to be used for citing. In other words, we don't really need you. We're really not, you're okay if you don't do these things, which is a shame. And unfortunately, the next patient, who's also not here, and we'll see if we can maybe we'll go through this later. But this was a lovely young lady who was not in for a surgical complication. She was in for a partial bowel obstruction. And what as typically happens, on the night before discharge, all her clinical endpoints had been met. So they were de-escalating all her clinical interventions, but the pain orders always stay, right? So she just had an NG tube, and she was given a large dose of Dilaudid and stopped breathing and was found in respiratory arrest in the early morning, did not make it home. Another tragic example of this issue. So let's keep going. 2015, the literature, we have this study at Case Western, Freudian slip, Cleveland Clinic, about continuous blinded monitoring of SpO2. And what they found there, the patient providers did not see the pulse oximeter. They found that over a third of the patients had prolonged periods of hypoxia, and that the frontline providers were not aware of that hypoxia. So hypoxia, we all think, is not such a good thing. Unfortunately, the study didn't tie it to outcomes, which would have been great. But what it did show is that a lot of things are going on behind closed doors on the wards that we don't know about. And that continuous monitoring can shed light on this. One of the first systematic reviews, analysis of multiple studies that tried to answer the question from an evidence standpoint, is non-invasive continuous respiratory monitoring a good thing? Here's a forest plot of the ratio of severe adverse events, continuous versus non-continuous. And you don't have to be a rocket scientist. You can see on average, the weight of the scale, that was a balance, would be towards the left. It would be favoring a trend towards fewer serious adverse events with continuous monitoring, but confidence interval span 1. So it's not wholly convincing, but it was one of the pieces of the literature that people are using to make that decision. Now, this was a good paper also in 2015 from Lori Lee from the APSF, and that was a closed claims analysis of from the Anesthesia closed claims database, I believe 92 cases. And the most telling thing here was this bar chart you see here tells you about the time between the last time the patient was checked on and when they were found in respiratory arrest. What you can see, the highest bar is at an hour. So most patients were found within an hour of their last visit. The standard of care, by the way, is Q4 hours, right? Anybody know 240 minutes? Anybody know where that standard of care comes from, Q4-hour monitoring? Ever been shown to be safe and effective? Good idea? We have patients on the ward, right? This is people who they're not sick, they're just hanging out, getting some antibiotics. This paper, this timing, very, very key to understand. There are some moves afoot to try and decrease that interval of timing to Q2 hours. Well, let's move the red bar a little bit to the left. What did we do there? Everybody happy we're effectively addressing this problem? We're really not. But now this was this was really 90 cases. Now I've seen about 50 cases in 15 years, and there may be one anesthesiologist named in all of those because our responsibility typically ends at the PACU door. So this is not representative. It's the tip of the iceberg. But there was a lot more of these patients out there. And so that was in 2015. All right, we got Tom. Well, look at the size of this guy. An Irishman who plays the drums. I love that. Tom came in for elective surgery, repeat back surgery. Tom had no risk factors. He did snore a bit. I snore. Anybody else snore? And Tom was found dead in bed while his wife was sitting in the room shortly after surgery. You go down the list of differential diagnosis, and in my mind, and with my experience looking at these cases, he received an aggressive dosing of Dilaudid. Completely unnecessary, completely preventable harm, and a tragic, tragic outcome. So let's move on to 2016. Dave just gave us a nice presentation of who ECRI is and ECRI, what they do, specifically regarding devices, which include monitoring devices. ECRI is a great organization focused on safety. I think ECRI was trying to get out ahead of the oximetry debate, and they said, well, we're going to recommend monitors to detect opioid-induced respiratory depression, which is what we're talking about, ORI, AVI, need to continually assess ventilation for the first 24 hours. So two things, a ventilation monitor, 24 hours. They evaluated capnography and bioimpedance devices, and I can tell you exactly, you can read exactly how they graded those. They favored one over another. And lastly, they said ECRI does not recommend purchasing a pulse oximeter to monitor patients on opioids. And I thought that was overstepping, greatly overstepping, and actually a very dangerous recommendation. Because if you look at the evidence, I just showed you that the evidence is quite scant, and there's different ways to interpret that. By the way, everybody knows that there is no evidence that a pulse ox in the OR improves outcomes, right? So we expect at least half of you evidence wonks to throw your pulse ox out on Monday when you go back to the OR. This was the study from LAM. I don't know whether the team, and ECRI has a team of experts that evaluate the evidence and use expert consensus as well. This was a study that came out shortly thereafter from LAM. This is Francis Chung's group in Toronto. And they went through this again, did a systematic review, a meta-analysis, and they found 9 studies only, 4 of continuous SpO2, 5 capnography. And they said, well, continuous SpO2 is associated with a significant improvement in the detection of desaturation and a trend, not a statistical difference, towards less ICU transfers. That's not bad. It's okay. We won't throw that out. And then they said the evidence whether SpO2 leads to less rescue team activation is inconclusive. Well, so not a ringing endorsement, but still looks like good things could happen if you monitor it continuously. And so I wrote a letter with Suzanne Bruns from Holland with a little tongue-in-cheek title, Continuous Pulse Oximetry Does Not Measure Blood Pressure. And if you look at this data, and it won't take you long because there's only 9 studies, and actually the ones we're talking about are 3 studies, most of them most of LAM's interpretation of the data was derived from Andy Ockroch's study at Penn in 2006. And Andy they just didn't look for reasons of transfer to the unit based on pulmonary reasons, but they also looked for reasons of blood pressure and heart rate. And what they found was that the patients who had oximetry were moved to the ICU much faster. Well, what we found in the Prodigy study, as what other technologies have found, is that you can do a very nice job diagnosing for first onset of arrhythmias, AFib, et cetera, with a pulse ox. So as it turned out, a lot of these were related to that, but when you look at the pulmonary, the early pulse oximetry warnings were able to reduce the number of transfers. So if you do the math again, if you run the meta-analysis again, you go from a hazard ratio of 0.6 to 0.4, and actually the confidence interval narrows. So stronger. So you really got to get down into the trenches to look at this data, because it doesn't make sense. If the data doesn't make sense, you got to check it out. 2017, this is the group up in Dartmouth. They are the premier group in researching surveillance, monitoring. George Blake started it, Andreas Tanzer and Sue McGrath have taken over. And they looked at some very interesting things. They said, look, For us, when we looked at patients on supplemental O2 and not on supplemental O2, we didn't see that the ones on supplemental O2 were slower to deteriorate or detect the deterioration. In other words, we didn't find that. They also found that respiratory rate wasn't as important as they thought it was. We all think of opioid-induced respiratory depression as low respiratory rate. That's actually not true. We're finally finding data that that's completely debunked. So what does this tell you? They're either telling us the oxygen dissociation curve is lies, is not true science, or they're very good at applying selective oxygen to the patients only that need it. And I hear John Downs clapping right now because that's exactly what they probably do. They keep their supplemental oxygen for those patients who are near the inflection point of the oxygen dissociation curve, where the monitor actually works linearly and where it'll show a decrease in oxygen. So throwing the pulse ox out is, I think, a little premature and something we should consider. A couple of things that happened last year as well. This is the Hospital Quality Institute, which used to be known as the San Diego Patient Safety Institute. They published a very nice best practice on how to reduce harm for these kind of people. And they actually have the bioimpedance monitor, one of the products out there on the cover. Make a long story short, they basically said there's 3 risk levels that you need to interpret in every patient. You got the very low risk patients, the low to moderate risks, and the moderate to high. The very low, you can do your spot checks. Portable monitoring, recommend periodic oxygen monitoring. What is a very low in their definition? A 30-year-old coming for an ACL who does not need a lot of opioids. That's very low. In my hospital, they come about once every full moon. Low to moderate risk, they recommend for low to moderate risk, recommend continuous oximetry monitoring. And for moderate to high, they strongly recommend ventilation monitoring, as the other recommendations have gone. So you see that this group really recommends continuous monitoring for the majority of your patients. A couple of things about Prodigy. So Prodigy, we put a put both capnometry and oximetry on patients who had received postoperative opioids in 16 sites, 6 countries, 3 continents. And there's some very interesting cultural differences between opioids. We basically looked for the traditional markers of respiratory depression, low respiratory rate desaturations. Notice this threshold, very long threshold, to satisfy the alarm fatigue issue. And also clinical events. So we wanted to see how many people got reversed and how many had positive pressure ventilation. We found 41% of the subjects had at least one event. And there's a variety of these events. 22 patients required naloxone or had to be intubated, and that's 1.5%. That's on the high end of what's being reported. Most interesting, though, is the patterns, and this is where we need to go with technology. This is the capnography pattern up here. You see there's rapid breathing and then these pauses in breathing. And you see the pulse oximeter here has this cyclical, this mountain range look to it. As they stop breathing, the sat drops. What do the catechals do? Make their heart rate go up, which is these green lines. And this is a pathologic pattern. And this is a pattern you can see on this continuous monitoring. Threshold alarms would not pick this up because we put those long periods on there. And what happens and so here you see a patient who's doing this pattern, and then they had to be resuscitated. And what's interesting here is this patient, why does this patient not have the cycling here? Because they were probably on supplemental oxygen. So the patterns are really, really key. Last thing, just in closing, everybody's seen this. APSF has dedicated an issue to this. Joint commissions come up with these standards. I'm just going to highlight. They basically say safe opioid needs to be an organizational priority. Hospital provides staff, needs resources and programs, as well as multimodal pain analgesia. Stay away from opioids if you can. And hospital leadership needs to buy some equipment and to monitor the patients. Solution: educate, multimodal analgesia, and monitor continuously. This sweet lady over here, Kim, was obese, OSA. She was with it enough to bring the CPAP to the OR, to the hospital. This is on our exit from the PACU to the floor. She got 20 doses of an opioid, and she was found in respiratory arrest with the CPAP lying underneath her bed in the middle of the night. Tragic situation, completely preventable. We need to, everybody needs to work on this. APSF is doing it the best it can. Two articles in the newsletter this year has been a tremendous awareness of this, but we need to go there. Lastly, Dan Sessler, who runs the Outcomes Institute, said in his 2016 Severn House lecture, it seems likely that continuous ward monitoring will soon be the standard of care, since vital signs at 4 to 6 hours clearly miss many of their rescue opportunities. Dan's a smart guy. I think he was wrong here, but we need to try and make this happen. 5 years from now, I don't want to give a talk with any more pictures. So please do what you can. Join the Rapid Response Committee at your hospital. Talk to the people about possibility of continuous monitoring, C-suite, all those different discussions. More monitoring, less marketing. Thank you very much.
I hope we have a recommendation to push everybody to continuous monitoring all the time. Okay, we have John Merkin next, our last speaker of the day. John is a leading anesthesiologist and a researcher from the University of Western Ontario in London. So thanks so much for coming up, John.
Well, yeah, thank you very much, Mark. I truly was honored to be invited to come down and speak to you all. I was very pleased about that until I started to review the literature and found that the lecture you tasked me with has virtually no data to support it. So with that little caveat, what I thought I would do, though, is, if you'll indulge me, just take you through some of the background to some of these newer types of monitoring and talk potentially about some of the potential applications then. And so I do have some disclosures. I was very honored, in fact, to be invited a number of years ago to the first research safety symposium held by APSF because I'd done some work with cerebral oximetry, and I think that's what prompted Mark to invite me here now. And we're currently doing some studies. Currently, I have no relevant commercial affiliations, but we have been funded to look at tissue oximetry, and so I'd like to share some of that information with you. And just by way of background, as you're aware, when one does near-infrared monitoring of tissues, we take advantage of the fact that there's this optical window, and so that the chromophores, those light-absorbing substances, are normally masked by water and melanin, but in this range from about 650 to 1300 nanometers, the absorbance of water is lesser, and so it allows us to pick up some of these other important moieties, namely oxygenated and deoxygenated hemoglobin, but also, as I'll share with you, increasingly some of the other markers of cytochrome and measures of oxidative metabolism. And so one of the more recent advances is that most of the conventional NIRS machines that we're using for cerebral oximetry use a limited number of wavelengths, and we're focused primarily on the oxyhemoglobin concentrations. But we're seeing the introduction of broadband NIRS, which uses a multitude of wavelengths. So it really allows one to look in depth at the various absorption spectra of a variety of chromophores within this optical window. And just very briefly to review, what we're looking at with this is using two different wavelengths, is this ratio between the amount of absorbance of the two different wavelengths that in this case are focused on oxygenated and deoxygenated hemoglobin. So it's really the balance between these two wavelengths and the absorbance that allows one to determine the amount of oxygenated hemoglobin in the tissues. With broadband NIRS, we can do repetitive iterations of the absorbance of other species within that. So it allows us to really be able to separate out the absorbance spectra of even a relatively low concentration substances such as the cytochromes, which I'll show you. As we've just had some talk about pulse oximetry, and of course I was, having been in practice for a few years, I was there at the introduction of pulse oximetry, like some of you here, and it has obviously revolutionized our practice, but there are certain concerns with oximetry related to potential malposition, motion artifacts, and other sites of parameters. And this does give rise to alarm fatigue. And the previous speaker obviously mentioned that that's a concern where one sets the threshold and how attentive the monitoring staff will be. Because again, we're not talking about one-on-one monitoring. We're talking about patients on the floor with varying degrees of support for the monitoring. So a little bit about tissue oximetry. Rather than looking specifically at delivery, which is what we get with pulse oximetry, here we're looking at the balance between delivery and metabolism. And so most of the conventional spectra, specifically for cerebral oximetry, use differential spacing of the optodes, the receiving optodes, to try to subtract out the amount of oxygen saturation appearing in cortical tissue. We had initially come up with a treatment algorithm that has very recently been validated, at least 2 multi-center studies. So what it says is, at least when we're monitoring cerebral oxygenation, there are physiologic steps that we can take that will improve the cerebral desaturations that we're seeing. So it is sensitive to global ischemic events, and it is amenable to physiologic interventions, but there's a number of limitations. There's a significant amount of extracerebral contamination. The analysis algorithms all assume a fixed arteriovenous partitioning, so the algorithm that determines the oxygen saturation within the tissues, and this can clearly change with changes in CO2, with changes in tissue perfusion, and it also measures a very small sample of the frontal cortex. We've been involved with some of the newer devices, and this is one that's using and incorporating a Doppler signal as well as the near-infrared waves, and the idea is to take advantage of a phenomenon that's called photoacoustic coupling, so that if the photons are insulated with a Doppler beam, it imparts a shift, which is called, they tag these photons, and so one's capable then of specifically monitoring or filtering out the non-tagged photons, and so we can get a much more representative assessment of tissue oxygen saturations at depth, and so removes a lot of the concerns about extracerebral tissue. And so we've done some studies, and the other group that's been heavily involved in this is the group with Chuck Hogue and his colleagues at Johns Hopkins. But looking at the ability of these non-invasive devices to detect the adequacy of cerebral perfusion, and specifically to look at the lower limit of autoregulation. So again, this is not directly related to the kinds of phenomena we're talking about here with narcotic-induced respiratory depression, but it does relate to the whole patient and whether their perfusion pressures are adequate to preserve their cerebral blood flow. What we've been looking at more recently, and I had the privilege now, we're just starting to work with our biophysics group, and they've just recently published this study showing now that using this combined broad spectrum near-infrared to look at an intense assessment of the absorbance spectra of tissues and using diffuse correlation spectroscopy, they can measure both cerebral blood flow and metabolism in this case in preterm infants, and we have a couple of studies now we're commencing in adult patients. But what this really does then is allow us to be able to detect the onset of cerebral ischemia, again, whether this is related to perfusion pressure, low oxygen delivery, or whatever the issue is. And rather than specifically looking at an amalgam of oxygenated, deoxygenated hemoglobin, here we're looking at the actual electron transport and getting some insights into actual tissue ischemia with changes in cytochrome C3a. So that's sort of the background. We've also been doing some work on tissue oximetry, and it uses a similar type of approach using these near-infrared wavelengths to detect saturation, in this case in the thenar tissues. And we published our first paper. This was used by our rapid response team. So being called to see patients on the ward that are in distress. And what we found was that the tissue oxygenation was the only independent predictor of mortality in these populations. So we've now got a prospective study utilizing this. I think we're up to about 450 patients, and want to see whether this is an independent marker for patient compromise that will augment the clinician or the response team's assessment of that patient. And more recently, we've also looked at patients presenting into our intensive care unit and shown the same thing, that their initial tissue oxygen saturations were strongly correlated with both a prolonged ICU mission and prolonged hospitalization. So this may be a means to help triage patients and assess the adequacy of their overall body perfusion. So it incorporates measures above and beyond just oxygen delivery. I think I'm going backwards. Whoops. There we go. Yeah. So back to the case at point. As we heard, the challenge with oxygen supplementation, when we put a patient on 2 to 3 liters of oxygen, we increase their FiO2, and obviously, because of the oxyhemoglobin dissociation curve, there can be a profound fall in their partial pressure of oxygen. However, the tissue oxygenation, the oxygen content of the blood, doesn't start to fall significantly until we get into approximate PO2 around 60%. And so the concern is that by whatever means we're monitoring tissue oxygenation or pulse oximetry, they're all subject to the same limitation. That until the actual oxygen content of blood starts to fall, these other devices, tissue oximetry, cerebral oximetry, as far as the oxygen saturations go, will not give us, I don't think, any greater insight other than pulse oximetry. There may be other aspects, however, because obviously, as was shown before, there are certain patterns that develop. And certainly we know that with CO2 rising, we'll be getting increases in cerebral blood flow. So if we're measuring blood flow or even cerebral tissue oxygen saturation, that may well be another sign that the patient's having a compromise. And I'm sure you're all aware of this older paper, but this was, I thought, a very impressive demonstration of just the impact, in this case, of 50 micrograms of fentanyl given to healthy volunteers with and without oxygen supplementation. And what it was really showing is that it took approximately 4 minutes in patients who are receiving oxygen supplementation until their oxygen content and the oxygen saturation fell to less than 90%. And of course, while that's occurring, there's also the recognition that hyperoxia itself has been shown at least to have some impact on both peripheral and central chemoreceptors, so may actually exacerbate the hypoperfusion. And of course, all of this ultimately results in a fairly profound respiratory acidosis. And certainly this has been associated, at least in other populations, respiratory acidosis is an independent predictor of adverse outcomes. So probably, again, that insult in and of itself, depending on the other comorbidities of the patient, may be enough to produce a very bad outcome. So this narcotic-induced respiratory depression, as far as the ability to detect that with oxygen saturation monitoring, I think really the conclusion is that one really needs to be looking at ventilatory parameters, so whether capnography impedance plethysmography, supplemented, and I support what was said previously, with measures of oxygenation and also the hemodynamics. And it really does take integrated multimodality monitoring. I think that's the challenge for the future, is to take these devices and really be able to define patterns that will ascribe that this is not a positional alarm, that this is in fact a real challenge to this patient having respiratory depression. So that was the extent of the remarks I wanted to share with you, and hopefully we're still on time, so thank you very much.
Stay right up here, John. So if you wonder how did the last two lectures fit into the medication safety realm, this all has an impact. And so to hear the newest monitoring, newest data from Frank and all really augments what we're doing today. So thank you, folks, for being here. Let's get the speakers back up, and then we'll be done by 5. If you would like to take a bus to the airport tomorrow, it's going to leave at 11:45. We've got 9 more spots if you'd like. And just make sure you let Stacy know. Be kind of on a first come, first serve basis, although maybe we already have everybody lined up. So thank you. The dinner this evening, by the way, it's going to be right over here where you got your lunch. It's the room's just beyond that table, Palmera room. So it's not a dinner, it's a reception, but it's tons of food. So eat and drink a lot, please. Okay, well, at least eat a lot. Okay, very good. We got questions. Jerry.
Yeah, Jerry Cohen. I have more of a comment than a question, but you can take it from there. As far as the proof of the value of oximetry, we always make fun of the fact that there's no proof that it works, and we're coming up with an idea at my place. But if it works, we're also going to study parachutes. There is actually evidence in Florida that it has worked. It's indirect evidence, and you can think of Florida as kind of like California light. In 1984, when the Nelcor finally arrived at our place, malpractice insurance was like $80,000 a year. That's $1984. Shortly after that, within about a year or so, it was down to between $12,000 and $20,000, depending on whether you were in Dade County in South Florida or North Florida. So there is some indirect proof that this works. The other thing that I thought as I listened a lot to the technology and how it's helping us had to do with the infusion pumps, which really kind of, well, it almost made my head explode. But I thought back as we went from really smart pumps that almost really made it tough on me as I got older, because it was supposed to help me, but I really preferred the dumb pumps that just told me mLs per hour because I couldn't screw them up. And even further back to the old dial-a-flow, or just a roller clamp and a mini dripper. Because
how old are you? No.
I didn't witness the first ether dome thing, but later than that. So at that point, your brain and the infusion rate was extremely tightly linked, and you had to understand the math so that if the electrons stopped flowing in a more sophisticated system, you could take over and actually make it work. I'm concerned today that with all the linkage, and especially between Epic, and I only pick on them because I know them well, and the pump, that we have a potential problem. If it was all that great, I think Lockheed, when they designed the F-35, probably would have come up with the Epic system, 15 mouse clicks and you could release your missile.
Oh, thank you. So yeah, I mean, one of the things sitting up here and listening to everybody and even speaking, we all in this room are authorities, and we're almost preaching to the choir. But one of the things that we neglect to talk about much is what Cass Sunstein writes about, and that's health trade-offs, right? Everything has repercussions. Everything has unintended consequences that we can't always foresee. We think we know what the best solution is, like I talked about barcoding and some other things, but until we actually roll things out, it's really difficult to see. And we talked a little bit before about the wrong route connectors that are coming down the pike. And our hospital was one of the first to adopt the NFITs, which were for G-tubes. And we had a conference on it about a year ago to go over it. And, you know, it seems like such a great idea where you can't hook in a IV lure any longer into a kid's G-tube. But they used to use the slip tip lures. So when we sent the kids home with their G-tubes, if the dog would run past the G-tube or the little kid, the little brother, it would just disconnect. But now our surgeons are, since we've been using the NFITs, they don't come off, and
Pulls it
the
out.
entire G-tube
Pulls
is
it
being pulled out right. And these kids
Yeah,
are
I've seen that.
going into the emergency room to get their G-tubes put back in under sedation. So, yeah, so Jerry, those are great points, and time will tell.
Rich?
Rich Prelip, Minnesota. I think I can summarize Jerry's comments that the concern as our technology gets smarter, our bedside providers get dumber. And that is obviously a potential concern. But I really would like to look at the issue of the barcode administration systems for the operating room. And obviously, this is a capital acquisition for potential institutions of some significance, a lot of education, a lot of maintenance. And my question is, where's the evidence? Where is there any evidence that the barcoding system actually reduces medication errors in the operating room?
Please.
So I think if you look, you will find it. The ECRI Institute's published about, in the ICU, I think there's plenty of evidence in that care area of reduced
The
problems.
OR, I'm interested in
Well, so till somebody does it, you know.
Okay. Jeff?
So for fear of offending anybody, but I usually only offend my wife, a few comments reflecting on what you all gentlemen spoke, but also earlier. One of the standards that I figured out from today is you cannot fix stupid. And I am so tired of hearing about the airline industry. I want you to all to reflect and look around the room at some of us. In the commercial airline industry, they retire you at 65. How many of you work in ORs today with surgeons and anesthesiologists, and we claim to be a high reliability organization? The airlines only have one death today, commercial airlines in the US, in 16 million flights. But the private airlines that don't have an age limitation, multiples above that. Thought number one for you. Two, Ron, going back to your comment about color coding, you know, if you believe in human safety factors, it's not that it's going to cure the problem. Vigilance, we know that even with barcoding, if somebody hears the word epinephrine, they might not hear 10 mics per ml or 100 because they heard epinephrine, they knew they had the right drug, and they give it. And that's been tested and shown. And by the way, if you don't hear well, you might not even hear the drug. Everything matters. And what worries me about today, but more importantly for tomorrow, we heard a lot of excuses why we can't standardize things, whether it's respiratory monitoring for opioids. Frank did a beautiful job of showing in 12 years we've gone nowhere. 12 years. 2010, this group met for this topic, and nothing has been accomplished in 8 years. It's time. It's not about your hospital. It's not about the University of Michigan. It's not about your system. It's about we can't have people driving on whatever side of the street they want, depending on what state they live in. This stuff has to be standardized. If we're going to be professional about it, we have to accept the fact if ISMP says you're going to put this coding, everyone's going to do it, we'll get used to it. But it should be standardized. From the drug company side, they should have colors that, whether you're a 503 or a manufacturer, the colors should be the same or don't buy it. Or you're giving lip service to all of this today, and you'll have another meeting in 8 years, and I'll be long gone, and you'll be no farther off. I'll let the smarter people behind me talk.
Yeah, those are all great comments. You know, when I made my comment before about the only way we'll change is for CMS to change it for us. I mean, I've been researching this for a while, and legal and regulatory solutions, and that's the only thing I can come up with. CMS forces us to do things, because if we don't do it, we get, those inspection problems, and every hospital fears lack of reimbursement. Joint Commission inspects on behalf of CMS, but remember, in most states, the hospital bases its licensure on the Joint Commission findings also. So we do have two, at least that I know of, two anesthesiologists now recently joined Joint Commission. We should invite them to the next APSF meeting.
A comment. When's the last time you knew that
Steve, can you get that on?
Joint Commission has evaluated preventable deaths in a hospital? Joint Commission checks whether you have too many radiology machines in the OR, in your hallways, the OR. It's always the same story when Joint Commission comes. Sorry, but it's toothless. CMS came out with this guidance, but then they cited best practices. But then they said, "Oh, don't worry, we're not going to cite you on that. It's what we recommend." We got to have some enforcement. I mean, patient safety indicators are falling off the map. You go to the CMS website and look at preventable harm. Half the hospitals not reported data. There's no enforcement behind this. And if we're going to be like aviation, when that patient was sucked out of that passenger jet, they grounded 737s the world over. Hundreds of flights were canceled. Inspections had to be done. We had half a dozen people stop breathing on opioids last night, and it was just business as usual probably today. So we have to have a better quality system.
There is one other way, and I think Brian Thomas could even speak to that. But when our recommendations are published in the APSF newsletter, or the summary of this meeting is published in Anesthesia and Analgesia or Anesthesiology, or when Brian Thomas's Physician Preferred Mutual, PPM, publishes their newsletter, and it comes in front of a jury, and the plaintiff's lawyer shows that to the jury, and the verdict's against the healthcare provider, that also makes a big difference. If we have to do that, we'll do that.
Matt Weinger from Vanderbilt. So I've had the fortune of doing safety research, not just in anesthesia and healthcare, but in nuclear power and aviation. And there's certain basic principles. I'm ultimately going to get to color coding. The basic principles are defenses in depth, i.e. don't have one way to prevent things, and in user interfaces, multimodal coding. And I would assert that barcoding is important. We need to do it, but even with it, we need to have other mechanisms of helping humans who are inherently fallible make sure they're doing the right thing. And imagine an anesthesia machine, much cheaper, that has no touch or location or color coding of the oxygen knob. We had that. Would we want to go back to that? No, because you need all of those different mechanisms, because you never know, given any given context, which of those is going to be the one that prevents the harm event. So we shouldn't be throwing out color coding. I agree that it's much more challenging outside the OR, but it's one of the things that we can control. And by the way, since I'm talking, I'll say barcode is like looking for your keys under the light, because that's where you can see them. It's a technology that sucks, and we need to jump over that and look at RFID type technologies for correctly linking the patient, the pump, the syringe, the dose, the EMR, et cetera, together.
So this is for Frank and David, and I probably should be talking to you afterwards. We've had continuous end-tidal CO2 monitoring and oxygen monitoring for any patient on opioids for about 18 months. And about a month ago, we instituted a new ERAS protocol for complex spines. We added in methadone. We switched, everybody used Sufenta infusion instead of whatever you wanted. So the first team that did it did all the new stuff, and then did all their old stuff too, which included now 2 milligrams of Dilaudid at the end of the case, and then the recovery room nurse gave a bunch of Dilaudid, and then she got, and then she went upstairs on a PCA. And her husband finally went and got the nurse because he didn't think she was breathing very well. So the nurse runs in, and the Untitled CO2 monitor is very faithfully reading a CO2 of 115. So and it's
For
a
Jan Arrowworth,
Medtronic,
that'd
and
be
so
right
that's
in
what.
line, right, Jan?
And so, Frank, I'd love to, with your study, if that's ever happened, we investigated if those Untitled CO2 monitors ever completely drain the battery, all the alarms reset back to nothing. So this machine had drained down at some point, and there was no alarm left on it. And we are working with Medtronic to say that's a problem. But it's just Murphy told me I had to bring this one up in case you guys have Medtronic Untitled CO2.
And your question again? 150, end title of 150, no. Although, as you know, a high end title is hard to be artifact. This usually has to come from somewhere low, which happen all the time. But and I don't specifically know that, but I haven't seen that. But there's a lot of systems issues in your request.
Love to talk to you about more about that.
Steve Barker, yet again. I am sorry. I know I've used up my quota. I swear, Mark, I will shut up after this. Mark my words. But Dr. Merkin, I couldn't resist asking you this. First, careful disclosure. I am a paid consultant for Massimo, and I am a member of their board of directors. You very beautifully pointed out in your talk the limitations of saturation monitoring. Once the PaO2 reaches values of about 80 or so, the saturation is 97, 98, and you don't know whether the PaO2 is 80 or it could be 450 if you're using supplemental oxygen, and you showed that. Are you aware of the more recent developments from Massimo of the oxygen reserve index, which is something that's measured by multi-wavelength pulse oximeter, 6 or more wavelengths, and actually trends with the PaO2 for PaO2 values between 80 and about 200. It's not FDA approved, another disclaimer, but multiple publications on it, including Richard Applegate and Peter Schmuck has done inductions on kids, and there was another paper just recently. So it looks promising, and it's in clinical use in Europe and Japan. What do you know? What do you think about it, and would you be interested in doing some research on it?
Well, no, I'm not aware of that particular technology at all. And yes, would be very interested.
Is that on, Steve?
I mean, how it... Oh, sorry. Yeah. No, I haven't. That's intriguing. I'd be interested to talk to you about the actual mechanism of action, how it's actually doing that, and I'd be very interested in seeing it in practice.
Well,
yes,
let's
absolutely.
talk. I won't take your time now.
It sounds like one you can take offline, I think.
Yeah. We'll take off. That's my takeoff line. Cleared for takeoff.
Okay.
Jim Suchik, Michigan Medicine. This is sort of a point of information for Tim, and a thanks to you for putting the documentation before administration as a change in our workflow. I try and teach that when we're using our AIM system. However, there's a lot of reluctance amongst a lot of clinical practitioners who are, berating the resident for not focusing on the patient and not doing all this. And it's like, once I've demonstrated that I can control the ventilation, I go back to documenting, let the minimal decision support on my AIMS, calculate out the weight-based dose and such. So that is something that I think needs to be really important. The one thing I worry about is something that the award winner mentioned about infection control. As I'm interacting with the EHR or the AIMS system and my syringes and the patient, how do I do this without getting goo all over everything?
You have Art right behind you, or Andy. Andy, why don't you step up and answer that?
I'm sorry. No, I just...
The goo all over when you're trying to do your documentation, because you presented that as an issue in the operating room, that we're very bad about keeping our stopcocks clean.
Yeah.
And the more I have to interact with another piece of equipment, i.e. in addition to the anesthesia machine, the medication documentation record I'm now interacting with, and I'm getting spit all over everything.
Yeah. I don't have an answer for that. I mean, I think we have, seriously, I spent the last year just immersed in anesthesia infection prevention. on a writing panel with the Society of Hospital Epidemiologists of America, and Richard Prelip was also involved in that. And there are a ton of really complicated, unsolved infection control issues having to do with anesthesia workflow that we don't have answers for, and I don't have an answer for that.
And Andy, before you ask your question, Rich, do you want to say what you and David Ermbach have just done?
Just a quick comment on that issue of our workflow and contamination. There's at least two strategies that'll be coming out in the journal Anesthesia Analgesia. One, of course, is double gloving, which I think many people already implement. The other is you can foam the alcohol-based hand foam your gloves and do a pretty reasonable job of actually sterilizing your gloves just as well as your hands. And testing the integrity of those gloves, they can withstand at least 6 exposures to the alcohol rub without any degradation. So stay tuned for some of that. And the other thing I'll add parenthetically is this whole issue is going to be addressed by a white paper, hopefully coming out in the next few months, by SHEA, which is a group of epidemiologists and ID experts, the Society of Hospital Healthcare Epidemiologists of America. And this will address virtually all of the workflow issues related to infectious disease and our anesthesia practice, with the exception we will not address OR attire.
And Rich did represent APSF on that, so thank you. Andy, back to you, and then Jim, and then we're going to close it down for the day.
I just wanted to thank Ron Lippmann for citing our landmark study showing that you can get an anesthesiologist to do anything for a free coffee card. And I just want to point out that we've gone on to do a much larger trial testing and proving that hypothesis with much larger numbers of providers that will be published in Anesthesia and Analgesia.
Was it more coffee? More coffee?
Coffee or Chipotle? Okay, coffee.
We'll switch from coffee to better things in a little while. Jim Phillip, Harvard Medical School. When we wrote the Harvard Anesthesia Monitoring Standard in about 1985, we said ventilation monitoring was one of the key issues. Frank, in talking about monitoring in order to protect against the final hypoxemic event, shouldn't we really be monitoring minute ventilation when we can?
Of course, it's good. But monitoring minute ventilation is a little harder outside the aorta than is inside the aorta, Jim.
But as you pointed out, impedance monitoring is on the market, FDA approved, ECRI endorsed.
It is, and let's get some studies in that setting. And to my knowledge, we don't have those yet, but I know Respiratory Motion is working on them. And Jenny wants to maybe say something. But okay, well, there are, but and we're not looking for that needle in the haystack, show improved outcome. We're just looking for the same kind of levels of evidence. So your point, Jim, our point still is that oximetry, none of these patients I showed you were found with a saturation above 90. None of them. Okay.
One minor question. IV drip rate, we can't measure when we're running our pumps if we don't know the volume of liquid in each drop. That ought to be said more clearly on our IV sets. One of the validation, David, that you pointed out was that's what we ought to understand and look at. And we don't know if it's 10, 15, or 20 ml per, 10, 15, or 20 drops per ml.
Okay. Good. Okay, folks, it's been a wonderful day. 6 o'clock to 9 o'clock reception. Thank you very much.